first speaker أستاذ الدكتور حسام العربي. His talk will be أستاذ حسام العربي. His talk would be about early intervention for prevention of macrovascular complication. أنا مع الأسف يعني ما عندي الببليوغرافي مال الأستاذ حسام العربي. نعم، أستاذ أمراض القلب في جامعة أسيوط. أهلا وسهلا.
أهلا بحضرتك. ربنا يخليك دكتور مصباح. طبعا بشكر الدكتور مصباح وبشكر Upper Egypt Diabetes Association for the invitation. أنا سعيد إن أنا موجود معاكم. Actually, the presentation is about early intervention for prevention of macrovascular complications. First of all, what are macrovascular complications? Macrovascular complications are diseases of the large vessels. The pathophysiology is atherosclerosis. It can affect cerebrovascular vessels, causing stroke, peripheral vascular disease, causing peripheral arterial disease, and the cardiovascular disease, causing myocardial infarction. The risk factors for macrovascular disease are the traditional risk factors for atherosclerosis. Hyperglycemia with defective insulin actions, one of the main mechanisms, in addition to other risk factors like dyslipidemia, hypertension, coagulopathy, increased age, increased reactive oxygen species, and altered matrix protein, and altered endothelial smooth muscle cells and macrophages are contributing factors for the process of atherosclerosis. The prevalence and risk of macrovascular complications. It was found that the prevalence of macrovascular complications in people with diabetes is decreasing, especially in elderly, especially for ischemic heart disease and stroke more than peripheral arterial disease. This was found especially in the age more than 75 and is not present in those under the age of 45 according to this recently published study. In Egypt, actually, mortality due to cardiovascular disease represent 46% of mortalities due to non-communicable diseases. And this is a large number. The pathogenic mechanisms associated with macrovascular complications. One of the main mechanisms is protein kinase C activation, receptor advanced glycan in the protein RAG activation. This occurs through hyperglycemia, diabetes, excessive fatty acid release, insulin resistance, causing vasoconstriction through decreased nitric oxide, increased endothelin, angiotensin II, and inflammation through decreased nitric oxide, activation of nuclear factor, increased angiotensin II, activation of activator protein 1, and thrombosis through decreased nitric oxide, increased tissue factor, plasminogen activator inhibitor, and prostacyclin. All of these can lead to atherogenesis. The low levels of soluble decoy receptor for advanced glycation in the product is one of the main mechanisms for the occurrence of macrovascular complications, and endothelial dysfunction is one of the main contributing factors that can be caused by several traditional risk factors like dyslipidemia, lipemia, hypertension, genetic predisposition, and diabetes with associated hyperinsulinemia. And this endothelial dysfunction increases the cardiovascular risk in patients with impaired glucose tolerance and type 2 diabetes according to the findings in the HORN study. So, these are the risk factors: hypertension, dyslipidemia, diabetes, family history, lack of physical activity, high-fat diet, and smoking. All of these are traditional risk factors for atherosclerosis that can contribute to macrovascular complications. So how to manage macrovascular complications? There are several ways by controlling these risk factors. We'll discuss each one. Dietary changes and weight loss and physical activity cessation of smoking, lifestyle modification. This lifestyle modification was found in several studies to be effective in reduction of macrovascular complications. This is a study published last year, showed that a healthy lifestyle and a higher life essential 8 score, that's one of the scores that calculate the lifestyle, were associated with lower risks of macrovascular and the microvascular disease among participants with type 2 diabetes. So lifestyle modification is very effective. Managing macrovascular complications through control of dyslipidemia is another way for prevention of macrovascular complications. Actually, hypercholesterolemia in Egypt was found in 37% of Egyptian population. In the EuroAspire 5, it was found that LDL cholesterol more than 100 milligram per deciliter in patients not using lipid-lowering therapy was found to be present in 84% of the population worldwide, and in Egypt it was 62%. Large number of patients were found to have high LDL cholesterol, and they are not known to have dyslipidemia and are not on lipid-lowering therapy. While in those who are on lipid-lowering therapy, LDL cholesterol more than 100 was found in 47%, and in Egypt in 44%. So a large number of people who are known to have dyslipidemia for primary prevention. Those are patients with primary prevention with no atherosclerotic cardiovascular disease, have a high prevalence of high LDL cholesterol. This is a U.S. Preventive Service Task Force about the statin use for primary prevention of cardiovascular disease in adults, recommended that in those adults aged from 40 to 75 years who have one or more cardiovascular risk factors like dyslipidemia, diabetes, hypertension, smoking, and estimated 10 years cardiovascular risk of 10% or more, statins are recommended, and this is B recommendation. For those with estimated risk from 75 to less than 10%, it is also recommended with a C recommendation, just change in the level of recommendation. They concluded that current evidence is insufficient to assess the balance of benefit and harms in those who are 76 years old and more. In this study of rosuvastatin, Meteor study, they assessed the rosuvastatin 40 compared to placebo in those with modest hypercholesterolemia and found that development of atherosclerosis can be slowed or even in low-risk asymptomatic patients with LDL reduction of 48% and HDL increase of 8%, and with a change in carotid intima-medial thickness regression with the use of rosuvastatin, even in those who are asymptomatic with no much elevation of LDL. Also in HOPE-3 trial that included patients with just risk factors for atherosclerotic cardiovascular disease with no atherosclerotic cardiovascular disease, the use of rosuvastatin 10 milligram reduced primary endpoint of reduced cardiovascular death, MI, stroke, cardiac arrest, revascularization, and heart failure by 25%. خلاص? And stroke was reduced by 30%, and the myocardial infarction was reduced by 35%, and coronary vascularization by 37%. So, even in those patients, we can start statins early for prevention of macrovascular disease. Regarding hypertension, you know, if there are structural alterations that occur in the arterioles with negligence of treatment of hypertension. If you imagine here the normal blood vessel, you can, with a radius of 1, you have an arbitrary unit of resistance of 1. With vasoconstriction 10%, we have a reduction in the radius by 10% with increase in the resistance to 1.5. While with negligence and occurrence of hypertrophied arteriole to 0.5 radius, we have an increase in the resistance to 16.3. And with vasoconstriction 10%, the resistance increased to 39.2. This means structural alterations in the vessel wall with negligence of hypertension treatment can have important functional implications, and it is very important to prevent such structural alterations by early treatment of hypertension and preferably use those drugs that can cause regression of these structural changes. This is why the European of Hypertension recommendation guidelines, the recent guidelines recommended start of treatment, drug treatment in patients with blood pressure from 130 to 139 and 85 to 89 high normal blood pressure if there is a high cardiovascular risk, and to start immediately drug treatment for grade 1 hypertension. So blood pressure lowering treatment should be based on cardiovascular risk and target those at greatest cardiovascular risk irrespective of their blood pressure. It is the opinion of the task force of the guidelines of hypertension that support earlier treatment of patients with systolic or diastolic blood pressure values more than 140/90 when there is cardiovascular risk is low or moderate, to prevent the accumulation of hypertension-mediated organ damage and high incidence of late treatment failure residual risk, which could otherwise occur if treatment was delayed by the patient or the physician. This is a paper from the United States published last year saying that early management of hypertension by general practitioners can improve the cardiovascular outcomes by adhering to the target blood pressure guidelines, assessing cardiovascular risk, encouraging lifestyle changes, and recommending multiple drug regimens. Accessing the patients through the general practitioners can improve the cardiovascular outcomes. Regarding the platelets, there is no doubt of the importance of aspirin for secondary prevention, but for primary prevention, it is doubtful. This is a paper published last year for aspirin with or without statin in individuals without atherosclerotic cardiovascular disease across risk categories, and they found that the bleeding risk outstands the benefit obtained from aspirin use in those patients with or without statins. And the conclusion, the anticipated absolute risk of major bleeding with aspirin exceeds the absolute myocardial infarction benefits for early level of atherosclerotic cardiovascular disease. So in those patients, don't give aspirin. Lastly, regarding diabetes. Actually, I'll not speak about diabetes in a conference with diabetologists. So I'll go rapidly through this part. You know that macrovascular complications start early before the diagnosis of diabetes, unlike microvascular complications. This is why we have, and the risk of cardiovascular disease is 2 to 3 times higher in pre-diabetics compared to individuals with normal blood glucose values. There is no approved pharmaceuticals for pre-diabetic patients. And however, some prevention studies have shown that early intervention with lifestyle modification or pharmacotherapy may slow down progression of diabetes by delaying the underlying pathophysiology of the disease. These are some studies about lifestyle modification, and you see the benefits ranging from 34% up to about 60% with lifestyle modification in the reduction of the progression of the patient to diabetes and the reduction of target organ damage. Using pharmacotherapy for pre-diabetics, there are several studies with metformin, rosiglitazone, acrabose, and pioglitazone that showed the benefit with the use of these drugs in pre-diabetics. However, the recommendation, the algorithm for management of pre-diabetics in the diabetes guidelines recommend lifestyle therapy and only metformin, acrabose, and if glycemia is not normalized, you can consider with caution TZDs or GLP-1 analogs. You know, even in those who are having diabetes mellitus, the trials failed to show a benefit regarding macrovascular complications. يعني 1 minute. Regarding macrovascular complications, and with the use of DDP4 inhibitors, also we had only neutral outcomes with no benefit. And the benefit was obtained by GLP-1 analogs, as you see here, with reduction in patients with already having atherosclerotic cardiovascular disease and those with multiple risk factors. However, the benefit with multiple risk factors, as you see here, is less obvious than those with already having atherosclerotic vascular disease, with no benefit regarding the occurrence of heart failure. While SGLT2 inhibitors trials, that includes a variety of patients. In EMPA-REG, patients with, for secondary prevention, 99% having cardiovascular disease, and in Canavas, 66%, only 34% with 3 or more risk factors, and in DECLARE, a large number of patients included in this study having 2 or more risk factors with no cardiovascular disease. So the outcome was reduction in the 3-point MACE, reduction of death from any cause, cardiovascular death and heart failure with empagliflozin, and with canagliflozin, the same 3-point MACE was reduced and hospitalization for heart failure was reduced, while in dapagliflozin, which include about 60% of patients with just risk factors, the 3-point MACE failed to be significant, with a reduction of heart failure hospitalization by 17%, and with subgroup analysis, those with prior myocardial infarction showed a significant reduction in the primary outcome. What about the cardiovascular protective effect? When you look to the trials of SGLT2 inhibitors, you will find in patients with the reduction in heart failure is uniform, regardless of the presence of atherosclerotic cardiovascular disease or multiple risk factors, while in MACE, only in those with established cardiovascular disease have a benefit, with no benefit with multiple risk factors. So we can use these drugs for primary and secondary prevention, for reduction of renal protection, hospitalization for heart failure, while major adverse cardiovascular events only for secondary protection was proved. In summary, macrovascular complications include stroke, myocardial infarction, peripheral arterial disease. Atherosclerosis is the central mechanism of these. Several diabetic risk factors are associated with macrovascular complication. Endothelial dysfunction is a central mechanism. Guidelines recommend the control of these risk factors, and the cardiovascular outcome trials are underway to evaluate cardiovascular outcome and primary endpoints for currently available therapies and drugs for development of type 2 diabetes. شكرا.